Dr. Grieb, Dr. Landsman, Dr. Kachukos, members and guests. Allow me to say that it's a particular honor for me to present to you today here in New York, and particularly in front of my former mentors, Dr. Eva and Dr. Randall Grieb. Thank you for having me here. Valve-sparing procedures have been progressively recommended for aortic repair, especially in young patients. And as we've just heard from distinguished leaders in the field, are being utilized with great technical success, even in patients with connective tissue disorders and congenital bicuspid aortic valves. The durability and long-term outcome of valve-sparing procedures, however, has never been shown to be superior to the results with the established root replacement procedures. When Hugh Bental and Anthony De Bono in 1968 originally described their technique for complete replacement of the aortic valve in a 33-year-old male with a large globular dilatation of the ascending aorta and aortic valve ectasia, they presented a new technique, and it was a daring step at the time. It was about technical feasibility, and then in 1977, the chair of this session, Dr. Kachukos, published the initial experience of the first 25 cases with his modification, the button Bental, likely one of the most significant refinements of the classic procedure until today. And then Dr. Gala, Dr. Landsman, Dr. Grieb in 2002 presented their biological Bental procedure, a solution for patients deemed unable to take anticoagulants with an excellent freedom from thromboembolism and structural failure, as you can see here. And there's many more contributors to the success of this procedure. Some of them you see here, Dr. Jean Bachet, who presented the first 203 patients, comparing the three different techniques available at the time. Christian Hagel, who presented a benchmark series in 2002 on 142 young patients, and as we just heard, Hugh Cameron on the Marfans. So let me come to the Leipzig experience. Out of 1,200 procedures, we selected 448 consecutive composite Bentals. There was one single conduit used, and there was 100% follow-up with a median of 6.3 years. Here the intraoperative data. It's really nothing special about these numbers, except maybe that you see here axillary cannulation is used in about 50% of the acute type A dissections and 5 to 7% only in the other etiologies. Risk factors, multivariate analysis for all death. Again, factors that are not really surprising: age, emergency surgery, cross-clamp time, radiocardiac surgery, and previous CVA. But I want to point your attention to two things that we've seen previously. Axillary cannulation seems to show a trend towards sort of protective trend for all death, and female gender turn out to be a risk factor. That's something that we've seen previously. This was a paper that we published at my time at Sinai in 2008, when we already found that axillary cannulation improves survival and neurologic outcome after atherosclerotic aneurysm repair of the aortic root and the ascending aorta. And we've also suggested, although we didn't really know at the time what the reason for that was, that women have a less favorable long-term outcome after biological Bentals. And it seems that this applies also for the mechanical composites. This is a long-term survival after mechanical composite aortic root replacement in these almost 450 patients. You see here the green line is the age and sex matched Eastern German population survival and numbers at risk. We have still 80 patients after 10 years. And you see that the long-term survival after the first year is equivalent to an age and sex matched population. That's the first good news. There's more good news to come. Survival after hospital discharge. If you compare the three main etiologies that we included here, aneurysm, dissection, and endocarditis, you'll also see that there's no equivalent survival after hospital discharge. No different survival, sorry. If we look into the bicuspid and the tricuspid patients, you can here already see that there is a difference in long-term survival between these two groups. The bicuspids have a better long-term outcome, although they are also younger. So if you look only in the bicuspid patients that are, or in both groups, and patients under 60 years of age, you see here that this difference becomes more significant. And if you look into the bicuspid population and their age and sex-matched normal control, you see that there's virtually no difference, particularly not if you exclude the first 30 days and look only after hospital discharge. You see there's equivalent longevity in this population. This does not apply to the tricuspid patients, obviously. This is the long-term survival of this population. You see here, as compared to the age and sex-matched population up here. If you do this comparison again, look only after hospital discharge, you see that there is a continuous decline, which is significant. So after hospital discharge, the tricuspid patients have an inferior survival. Last but not least, the comparison between men and women. Again, you see here that female patients appear to have a less favorable long-term survival. This is, as I've shown you before, a notion that we've made before in the bioprosthetic valved conduit population we published a couple of years ago from Sinai. So it really seems that longevity in women is less favorable after this type of operation. We don't know yet why that is the case. Conclusion, early mortality is different. However, survival after the first year is equivalent for all etiologies. Bicuspid patients who survive the first year are cured. Their survival is equivalent to that of an age and sex-matched East German population. Thirdly, long-term survival for tricuspid patients is not as favorable and even worse for women. And our experience shows a trend in favor of axillary cannulation, and it might prove advantageous in the future as an arterial access in all aortic pathologies. So underlining what Dr. Keimeron just said, we also think from this experience we can tell that the mechanical Bantal operation is an excellent option, particularly if conditions for valve-sparing procedures are not optimal, and it seems to be particularly good for young patients with bicuspid aortic valves. Thank you very much.